So we're going to try and do a 3-hour session in 15 minutes. I'm sure we can do a good attempt at that. Um, and just move that there. Right. So when we look at SGBV, and we know that it is now a national crisis, and I'm very glad that we moved into that section. And it's also the activism time, which I think should be every day of the year. When we look at 2018, a study that was done by WHO saw that if you look at SOGI from 50 countries, the physical violence aspect for LGBTIQA plus people was around about 12% to 68%. And this is now over the 50 countries. And if you look at sexual violence, it was 7% to 49%. However, if we go to Miller's study that was done in Southern Africa and East Africa with 832 participants from South Africa, which included then 232 trans and gender diverse people. This is the stats that we get from that. So if we look at cisgender women, so lesbian women or bisexual women, we could see that physical violence was 50% lifetime and 13% in the last year. So that was 2018. If we go and look at transgender women for physical violence, it was 63% lifetime, 33% over the last year. 52% of transgender men experienced it in lifetime, 23% the last year. And if we look at gender non-conforming people, it was 73% lifetime and 24% the last year. If we look at sexual violence, it is quite horrific. Again, if we look at, let's say, a gay man, so cisgender men, it was 40%, 16% the last year. But with our trans women, it was 67%. Last year, 35%. 50% of trans men, 28% the last year, and 71% of gender non-conforming, with 24% the last year. So again, significant numbers that we are seeing there. And for myself, working in one of our tutuzelas, that is a rape crisis center, we have become very aware that all people arriving there that are survivors of SGBV are traumatized. All of them have gone through a lot of pain, trauma, that kind of completely being overwhelmed. However, there is still the factor of being re-traumatized within our centers due then to sexual or gender diversity. And that is highly problematic. So a group of us had the opportunity to develop a training manual providing safe and affirming post-GBV care for LGBTQI plus patients and clients. And we did this in collaboration with the Medical Research Council. And I want to quickly look a little bit at that due to the time that we have left. I'm going to focus on that. You might have seen that I did put up the whole idea of hate crimes as well. And we know that we now have also a hate crime. The bill has already been passed. And we know that is a criminal act where it is today to do with the prejudice within a certain group due to, let's say, LGBTIQ community, foreign nationals or Muslims, etc., where people are dehumanized and considered as different. And it can be actual or perceived. So a person can think, oh, this person is trans, but they aren't actually trans. So it's actual, they are trans, or perceived. So when we look at the rape crisis centers, the question there is, are we using affirming language? So when a person comes in, what do we say? how do we treat the people? Are we doing their real name? Do we ask them what pronoun they use? But we also need to realize that when you work in a Tutuzela and you have to fill in a J88, there is also an aspect called legal speak. So we need to use terminology that we can take into our court system, into the legal system, without landing it in a space, that we're not affirming our client. So when we go into the space where we, for example, need to examine our client, the victim, how do we speak to our client? How do we fill in the J88 that it's still legal, but we do not traumatize our victim even more? And how do we use compassion and care in these spaces? So I think the first thing that we need to realize is our spaces, our centers needs to be safe. It needs to be welcoming. Our intake forms needs to change to incorporate gender diversity. Do we have pamphlets that is also for our trans and gender diverse people? Or is it very heterosis normative, these pamphlets? Do we have any signage? I'm glad to say that the NPA brought out a wonderful poster that has gender and sexual diversity as part of that poster and signals with the inclusive flag. And then also, in our centers, do we have linkage to care outside their centers? Do we know where to send our client that's, let's say, transgender, but needs to go to a place of safety? And unfortunately, in South Africa, we don't have places of safety in general for our clients that's trans and gender diverse. So when we look at appropriate care, we know that in the beginning you need to open a file. You'll see it right at the bottom with the clock. On that file, we need to use the legal names, and not all of our clients would have already changed their legal name or their gender marker. So sometimes we've had experiences where a person walks in, the person is seen for the woman they are, but the moment they land up with the doctor, they realize this person may have a penis. And that creates a whole stir within this environment. So it becomes very important to train our healthcare providers, our clerical staff, the NPA, SAPs, everybody to become aware that we have trans people in our community that needs to access these spaces. Because that forms part of the problem. A lot of our people don't go to these crisis clinics that's trans and gender diverse due to the way they're being treated there. So when they go through the orientation process, how do we engage with our trans and gender diverse people? For the HIV testing, when they go to the doctor, when they go to SAPS, when the social worker do the disclosure and risk assessment, where do we send them for a place of safety? With our psychotherapy, to always be reminded when a trans person comes in, it's not necessarily that they're coming to us due to being trans, but in this case, they're coming to us due to being a victim of SGBV, and not to focus on the transness, but on the reason that brought them into our spaces. So when a person that's trans come to you for a flu, you don't treat them for them possibly wanting to transition, you treat them for flu. The same here. And when do we also refer to psychiatry? So in the entry point, the first contact and orientation for trans and gender diversity survivors, this stage is crucial. We need to use affirming language. We need to use the correct pronoun. And quite often what is good to say, my name is Chris, I use the pronoun he. Which name would you like me to use and which pronoun? That is a way to open that space. Privacy are essential to prevent secondary trauma or discrimination. if we need immediate medical and health support for trans and gender diverse people, the doctor's approach should be non-judgmental, with sensitivity to bodies that may not align with binary expectations. So when a trans woman walks in with a new vagina, we need to think, how am I going to fill in the J88? And how am I going to use certain words for genital configurations or hormone use? The same obviously happens when a person needs to be admitted into a hospital. How do we navigate those spaces? And how do we, in the end, make sure that we don't have this kind of invasive curiosity that can be re-traumatizing? Furthermore, we need to make sure that they're able to access affirming psychological care, but also that our psychologists and our social workers is trained in gender affirming practices. When we look at legal reporting and case opening, trans and gender diverse survivors often face misgendering, invalidating language, or even mockery at police stations. So we need to make sure that we also sensitize training with SAPs. And then going into prosecution and justice, we've developed a whole guideline for how to testify as well. This we did through the NPA, and it's a guideline that we also have trained across South Africa for people that testify in court. But it is very important to realize that also our courts are very binary. So if you, for example, think about when you have to speak to the judge, it would be my lord, my lady. But what if the judge is non-binary? What are we going to use there? So there's still a lot of significant work that we need to do there. And also to realize that it is a hate crime if a person has been sexually assaulted or there's gender-based violence due to a person saying, but you are a trans person, that is why I'm doing this to you. Maybe just to end, if we look at the treatment of trans and gender diverse people in our general clinics, so this is not only trauma clinics or where rape survivors go, we see that people that have been treated with less respect in South Africa due to their gender identity, 73% of that sample study answered positively to them. People being called names or insulted in their health facilities of their gender identity, 48%. And people being denied healthcare because of their gender identity was 39%. And just looking at these figures, we realize there's still a lot that we need to do and a lot of work that we need to do in these spaces in order to make it safe, to make it open. And we need to think of new ways to support our trans and gender diverse people to feel safe, new ways for them to be free and to be themselves in these spaces, and new ways also to change our systems to be affirming of all gender identities as they present themselves in this world. And that is a very short presentation on SGBV in this spaces. I'm handing back to Madeleine.
Thank you very much, Chris. You can stop sharing, and I'll just put on a QR code for the evaluation form.